that we get to share the story of two providers. So the title of our session is A Tale of Two Providers, Implementing Artificial Intelligence Documentation Technology to Drive Revenue and Staff Productivity. And I'm going to talk for a few minutes this morning and share with you some work Peter's team and our team did together where we surveyed folks. Some of you have heard me present other survey materials through the conference. But this, I have a few slides about some data that Remarkable was helping us take a look at. Then I'm actually going to turn it over to Peter. He's the head of Remarkable Health. And he's going to introduce his two customers and case studies to share their story. Okay? And as in all my sessions, you are welcome to interrupt at any time. And if you want us to do different slides, we can change slides. It's no big deal for us, okay? All right. Questions or comments before we get started? All right. So the first thing I'm going to cover is the findings from our national study on clinical documentation and technology. And then I'm going to talk briefly about the impact of poor documentation for providers and how technology can help you with documentation. Then I'm going to turn it over to Peter. He's going to tell us a little bit about Remarkable Health and some of the tools and technologies they have. And then Mary and Sue are going to share their stories about the technology that Remarkable Health has for us. Okay? So the study that we did was, we sent out surveys to 5,000 behavioral health organizations, and we got a 6% response rate. So some of you have been in sessions where we've presented other surveys, but this was done similarly, essentially us releasing a survey via email and then doing follow-up calls to get the response rate in place. In this particular case, we have 4 key findings, and so I would highlight this as the most important slide until we get to our case studies. 20% of respondents said they are looking to buy a new EHR within the next 2 years, but only 11% said they would recommend their own EHR. So, folks are, again, like some of our other survey results, are definitely looking for software, but they don't like the one they have. That's what at least these survey respondents gave us. The second key finding was that over 40% believe that reducing clinical documentation time by 50% would have the greatest impact on their ability to bill at full utilization. And 65% responded that their staff spend 7 to 11 hours a week on documentation. Any surprises in that? Folks saying they're spending a heck of a lot of time doing documentation. Does that sound like what you're seeing in your organizations? Yes, no, maybe? Yeah, William. No, this is actually for clinical documentation. So I'm a clinician doing my progress notes, treatment plans, assessments. Yeah, but that's a chunk of time. I mean, I'm only willing to work like 32 hours a week. So when you make it 11, it's, it's a third of my time. The third key finding, almost 70% of respondents expressed interest in purchasing an add-on to their EHR that would improve clinical documentation issues and was easier for clinical staff to use. It's one of the things that Remarkable is going to tell us about, the add-on software that they have. And then fourth, filling vacant positions seems to be the biggest challenge to providers as far as things impacting their cash flow and productivity. Again, no surprise there. We're seeing all sorts of work shortages, staff shortages in all sorts of settings. So that's sort of the big picture from some of the questions that we ask. Again, we were really focusing here on, what's impacting clinicians in terms of the amount of time they're spending on documentation and how that's disrupting how organizations are operating well. So again, clinical team members spend an average of 40% of their time doing documentation, so a couple days a week out of a theoretical 5. And despite that large investment of time, 15 to 45% of clinical documentation has missing or erroneous information. So the bad news is I'm spending a lot of time doing documentation, and the worst news is it's not very good, even when I spend 2 days doing it. So that's what we found, and it's also, we've also seen that sort of anecdotally when we're talking to providers. So we got a pretty pie chart for you here, looking at the number of billable hours a week a clinical staff person is doing, assuming a 40-hour week. 47% of staff are billing 26 hours or less. So for those of us who were trained as outpatient clinicians, I mean, even back in the 90s, I was supposed to do 32 or 35 billable hours way back when. And as you can see from our numbers here, that there are a significant number of folks who are not spending, a whole lot of time on their billable services, presumably because they're spending 2 days a week doing their documentation. Any surprises there? Would your staff tell you the same thing? My supervisor just told me to work more hours as a way to solve that problem of hitting my target, and really didn't care how much time I spent on documentation, but he was mean anyway. The biggest impact on increasing clinical staff's ability to bill at near full utilization. And what we did here is we gave them answers to choose from. Reduce clinical documentation time by 50% or more, using bonuses or incentives, and reducing no-show rates. Again, you can see that 44% review reducing documentation time is key. So again, no surprises there. People are spending a lot of time doing documentation. It's not necessarily very good documentation, and they all agree that doing it better and faster would allow them to do more billable hours or reduce unit costs, depending on exactly how you're paid. Overall time per week clinical staff spent on documentation. So here's a little more detail about that. As you can see, 47, the big pie piece at the bottom, are spending 7 to 11 hours. I do not know what these folks are doing up here. The 2% that are doing more than 20 hours a week, that's a lot of time doing documentation. Maybe they're doing psych testing or something, I don't know. But those numbers surprise me. But as you can see, there's a chunk of folks in all the categories that are spending a significant amount of time doing documentation. And I even think of a few years ago in our industry, as we were implementing electronic health records, people talked about, we really need to do concurrent documentation. We would do the documentation while we're delivering the service, so I wouldn't spend 7 or 11 hours a week doing it. But it seems like the reality in the world is there's not a lot of folks that are doing concurrent documentation, so they're doing it separately, which contributes to the stuff we're doing here. So this slide has to do with the survey results about the quality of the documentation. So we already know I'm spending way too much time doing documentation, but here, the rating of the overall quality, average 47%. Altogether, 53% responded that the documentation is average or below average. For high achievers like me, average is really not good. I mean, getting a C, so when it comes to documentation, anyone work in compliance department or oversee compliance stuff for documentation? Okay, so average is really not quite good enough for documentation. Excellent, 6% of folks here. The question we should have asked, and we talked about this, Peter and I and our teams talked about this after we did the survey, because this is the first year we did this particular survey. We should have asked also how much time the quality or compliance staff are spending reviewing documentation, because we haven't really captured that here. So if I'm spending 7 to 11 hours a week and doing bad documentation, then my colleague Doug is spending 2 hours telling me what I did wrong, and then I'm changing it again. There's actually more hours being spent than we ask questions about. So that's the question we'll add for next year, is how much time do your quality and compliance staff spend helping correct documentation? So factors that affect the greatest impact on growing revenue, profitability, and cash flow. Again, they had choices here. They picked all of the above, was their favorite answer. Staff positions filled and operational in 30 days. So your software has to be easy to use. It needs to be quick to train folks in order for people to be up and running. Billing at full utilization, billing services within 24 hours, and reducing staff turnover. They essentially said, yep, those are all right. This was interesting. So your organization is considering EHR system change or a new purchase in the next 24 months. In this particular survey, about a quarter said yes, we are, that's true. Would your organization consider an add-on product? You know, something you could link up to your current electronic health record if it helped reduce the time for clinical documentation and help make it better. Obviously, the big old piece there, which is almost 3/4, answered yes to that. And then Net Promoter Scores. Is everyone familiar with Net Promoter Scores? We deal with this all the time. Have you ever had, after you've had a service delivered, you're supposed to rate it on a scale of 1 to 10? Would you refer your family member or how happy you were with it? And you would give them a 10. You know, 10 would be great, and a 1 would be terrible. So it's a very commonly used tool in the marketplace. So you can score on a scale of 1 to 10. And we ask the respondents here how likely they would recommend their current EHR to someone. Again, if they're really likely, they would pick a 10. And if there was no way, they would pick a 1. And the bar chart here shows the responses. You know, most of them are in the 7, 8 range. And if you're familiar with Net Promoter Scores, anything below 9 is not great. You want everyone to be a 9 or 10, saying, yes, I would definitely refer folks. You don't want anyone on the far left side. They're called detractors. They move business away from you because they're not happy, they're not satisfied. And then you got these passive people in the middle, the 7s and 8s. So interestingly, from our survey results, most folks were essentially saying they didn't have a whole lot of opinion and they weren't going to recommend their current vendor. There's not many folks, as you can see, that gave their vendors a 10. So 20% of the respondents said they are looking to buy a new AHR in the next 2 years, but again, only 11% would recommend their folks. So what does all this mean? 11% would recommend their EHRs, 26% of executives are looking to replace their EHRs, and 70% looking for clinical documentation products to make it easier. So that's sort of the big picture. So let me just talk a little bit more about documentation and technology, and then I'm going to turn it over to Peter to do the more fun part and to share the technologies and his case studies. This should be not a surprise to anyone in the room. What are the problems with poor documentation? It's harder to bring on staff, reduce time spent on consumer care because I'm spending 11 hours a week doing documentation. It affects staff morale. If I'm really spending 2 days a week doing documentation, it makes me crabby as a clinician. Increased time spent on compliance and quality. The potential for revenue leakage, which is sort of a term we use on the billing side, where eligible services may not be billed. And then if it's poor documentation or missing documentation, we could actually have funds recouped by payers. So obviously, we all know there's lots of risks in terms of having poor or missing documentation. So I'm going to talk briefly about some of the ways technology can help with that, and then turn it over to Peter in our case studies here. So one of the technologies we've talked about a bit, if you've been with me the last couple of days, is the notion of mobile solutions, because if people can do their documentation while they're out seeing consumers in the field, in homes or community settings. In particular, disconnected, and some of you may have heard me use that term, that means you don't need to be connected to self-service or the internet, that there's some way you can bring a record or do documentation when you're out in the field, and then sync it up to the main system at some point. It's that ability to document services without internet or cellular access. Clinical decision support is sort of the technology term we use in the electronic health record industry for using software technology to help clinicians in making decisions about service plans, doing documentation, and other sorts of things. So broadly speaking, we call that clinical decision support. Some systems have built-in documentation templates, or they help you with evidence-based practices, or people have integrated Wiley treatment planning systems or other sorts of things in order to help clinicians do service planning and do documentation. And one of the newer cool things that Peter and folks will tell us about is where artificial intelligence is actually starting to really enter our market in terms of how electronic health record technology can help clinicians. You know, it's technology that allows you to capture at the time you deliver service the important things you need to document. Peter will tell us more about that. You know, so that could be voice to text. It could be just photo capture of scribble notes that you have. Text expansion is the notion. You know how when you're typing text, how your phone will spell out words for you because it'll guess. So that's the concept of text expansion. So that if you're using technology in your electronic health record, you won't necessarily need to type the whole words or blow things out. Technology that helps write drafts of clinical documentation. I've only seen rudimentary forms of this in some EHRs where, for instance, if you're doing a biopsychosocial assessment and you're answering all these questions, it begins to put together a report based on the data elements. You know, it begins to compile it so that you can edit it. There's more technology capable there in terms of artificial intelligence. And then lastly, the broad notion of artificial intelligence to aid you in writing notes that are compliant with whatever your clinical standards are, as well as better documentation. So with that, I'm going to turn it over to Peter and let him both tell us about Remarkable Health and the rest of the story. And I'm going to sit down and stay out of your way.
Thanks.
I'm going to go here.
So it's great to be here. Peter Flick, CEO of Remarkable Health. And so one of the, well, thanks for that survey. That survey, we partnered with Open Minds, and what we learned there was we validated a lot of the assumptions that we were seeing in the market. We as a company have been in the EHR space for several decades on the Medicaid, behavioral health and human service side. And one of the things we started to work on 3 years ago was this premise that that technology will evolve in the behavioral health and human service space, similar to how it has around EHRs in the physical health and dental space, which is to say more of an ecosystem of bolt-on products will emerge that will really drive staff productivity and create experiences that the EHRs with them, you know, by themselves are not fully executing on. And so we started to work on this premise, and you know, the first piece of data we had was folks are spending 2 days a week on documentation, and there's a massive staff shortage. For any of you who were in the earlier session, there was a great graph that showed sort of the mismatch of demand and supply in terms of people that need help and the people that can provide the help, and that was covering physical health and sort of all areas of healthcare. But there's a significant one on the behavioral health side. And so we started to look at that and say, as a company, we want to start to earmark a third of our R&D budget on a product or products that could really do one thing, could take the 2 days a week down to 1 day a week, and could be executed as a overlay product onto the EHR, and it could work with our customers, but it could also work with folks that are maybe on another EHR. And the data that Joe Paul shared, really to me, what it tells me is that, you know, only 11% of the market is truly happy with their EHR solution, but 20% of the market is, so the inverse of that would be, you know, 89% is not happy. But only 20% are really considering a switch. It's a big deal to switch out a monolithic system like an EHR. It's really like 8 products in one, and the NPS scores reflected that as well. So the average NPS score from this survey in our space for EHRs would be -31. I'm happy to say our EHR has a better NPS score than that, but it's a challenging software category. Because of all the things that, you know, people are having to do their documentation in the EHR, and that's a source of frustration. And so we started to hone in on this and interview our customers. We went out, we've got over 5,000 users and years of EHR data, and we learned a couple other things. We learned that on average, the time from when a session occurs to when a note is signed is 3.5 days, and that's problematic for lots of reasons. The amount of people that need to touch a report to get those notes in, people tend to do their notes in batches, and so they get time together and they'll do several notes at once. That's predominantly how it's done. And so it's done like our team does expense reports, kind of at the last moment when someone's saying, hey, you got to get it in. And then we didn't appreciate, but we really got a sense of how challenging and sort of consuming it is for the supervisors and the QA teams, anyone that's training new staff to just review notes, coach people up on, hey, you're making the same mistake again. Need you to make this change, and then you got to reread it to make sure that they heard you. That happens a lot. And so, and then I guess the last piece of data would be just the burnout aspect of documentation and the frustration. So we thought, what if there was a way where we can work on a solution that could sit on top of an EHR and make the note-taking process for progress notes, 10 times easier, essentially, and ultimately cut the 2 days down to 1 day. That was our sort of working premise. And so what we did was, we know technology, and we think we know the domain pretty well because we're in it every day. But we wanted a solution that was really designed from the ground up with customers. And so we went from interviewing 5,000 of our users, different 5,000 than this survey was done to. And then we started to have interviews, in-person interviews. We did over 100 of them. And then from that, we went out to 4 agencies, 2 of which are here. MHA and Wings are 2 of the 4 that we partnered with very closely to do a joint development partnership program, and really like, hey, we heard this pain point. We have 3 solutions on how we could solve it. Show them designs, get their feedback. Often we picked one of the 3. Often we came up with a whole other one that we hadn't even thought of. And that tight collaboration was, not only was it really fun, it was needed, because we came up with solutions that we just never would have before, right? So a couple examples, we sort of thought that, hey, we'll just put everything on a mobile device because a lot of folks are out in the field. And what we learned by really getting in there and getting feedback was folks want to use mobile to consume information, but not to create large amounts of information. They're not, if they're doing their notes in bulk, they're not going to do that on their mobile phone and do 3 hours of notes on a mobile phone. They're just not. We learned that there was a lot of anxiety and apprehension from the typical service provider that's going from session to session to session. And what happens is they're typically jotting, thoughts down on a notepad, enough for them to remember. Most of the times they're not doing, really comprehensive, pages and pages of notes. It's just what they need to trigger working memory to do the note later, and that they have only a few minutes in between sessions, so they don't even start to open up a note and jot it down, because there was a level of intimidation. Once I open that blank note screen, it's like, okay, I'm in hours of note writing mode, and I don't have hours of note writing mode, so I'm just going to delay. Then all of a sudden you're going home and you haven't done your notes for yesterday, you haven't done your notes for today, and it's just this going home every day. Do I stay late tonight, or do I go home to, my family or whatever? And so we wanted to build in this concept that we give you an easy way in like the 2 to 3 minutes after a session to do just a brain dump download in a secure HIPAA way on a phone, tablet, laptop, whatever's convenient, so that, and then have our system bells create a draft note for you. So when you are ready to go back to note writing mode, you have all of your drafts next to you, and you can see exactly what you wrote down. We've come up with this concept through deep interviews of snapping a picture of a page like this. So the ability to, in a HIPAA secure way, snap this picture, attach it to we call it a scribble, and you can put your notes in there, and then that is tied to that client. So when you're ready to write your notes, that information is sitting right there, and we can put that together. Voice to text was a big feature. And then ultimately, so we had these speed tools that started to emerge in the process. And we really had a very clear North Star. We want to cut it from 2 days to 1 day. That is how we're going to measure our success. And so we knew we needed speed tools, but we knew also part of the challenge, and we had examples of training materials that were used at your agencies and others. Like the orientation process is pretty intimidating. You know, what keywords you can use for a certain program versus another program based on your credentials. And so we started to amass this sort of this list of examples of rules that they teach in training, examples of notes where there's errors and what they tend to be. And then we use a natural language processing engine, which is our AI here, to basically parse the sentences apart and then enforce the rules that the agency has in the moment while they're writing it. And so the origin of this whole product, the initial idea, the spirit of it was, you know, I'm on a trip visiting customers, hearing these problems, and I come home and we're having a family dinner, and we do high lows with our kids. And my daughter's low was that she had a poor grade on a paper for school because of spelling and grammar issues. I'm a dyslexic guy. You know, I need Grammarly. That's like a tool that I use on a very regular basis. And so I was like, oh, hey, you could use that. And she wasn't interested. But when it came to me, I said, hey, you know, we have this problem. And my daughter sort of flippantly said to me, well, Dad, if you're so smart, why don't you create a Grammarly for them? And I was like, that's a brilliant idea. And so let's take speed tools plus this Grammarly concept to enforce rules that are really hard for you know, especially someone new to the agency who's maybe writing notes for the first time, like a case manager, so that it's catching it right in the moment while they're doing it. It has a way of training them, making them easier. Question? Yeah. So one great example. Well, I'll give you the transportation rule is a good example. Would you like to give that one?
Sure. You know, one of the things that we talked about, you know, with service providers in general, you know, there's a lot of direct service that happens while you're going to and from a place, but we're not reimbursed for transportation, particularly in case management, I'm thinking around. And so I was very clear that say, I'm not taking or transporting someone to the doctor, because that's not the service we're providing. It's all of the stuff in between that we're doing that makes that medically substantiated service. Yeah. So we took out, we took that out.
So if they write in the note, I was taking Sharon to this place, then Bells would catch that and serve up some alternative rules that yeah. Mary has in her agency is blessed to say, hey, you accompanied or assisted and focused, and then as a message, hey, focus on what you actually covered, because transportation is not really the service you're providing. Mm-hmm. So you know, Mary was a real sort of leader on this side of things. Is, you know, we sat with her and said, can you explain to us these orientation guides? We don't really understand them. And you know, there's a lot of rules that why don't you talk a little bit about just the evolution of some of those rules, and like in your agency, how they're a challenge.
Yeah, and for those behavioral health organizations in here, if you provide an array of service levels and service types, in ours, that's attendant care, case management, to therapy, to medication services, there are a wide range of services that are provided. And so having the language available to say, well, you're attendant care, you can't be doing this, or you're doing case management, you're doing more than monitoring someone. And so we were able to really craft and hone in all of these training materials that we have when we bring people on and say, this is the type of documentation we want to see. We've been able to incorporate it into the notes.
Yeah, folks, I think some of your staff said, oh, I get why, you know, after a couple of weeks of using it, we're like, oh, I totally get why, you know, what you were talking about in training, like, because it's reminding them in the moment while they're writing it. It obviously saves a ton of time on the back end because you're catching it up front. And I mean, that was really the gist of it. But one of the tricks we had to do was we had to figure out like who the actor is in the sentence. And because if they were recounting, you know, Sharon was transporting her son and they got in a car accident and she's got anxiety, well, there's nothing wrong with saying that. You have to know the specific use case and then start to train the system to be able to catch those things. So we had a couple other working like thesis. You know, you want to talk about what your idea was, and we ended up proving it out in the case study around.
Yeah, well, you're taking my talking points, but it's fine, Peter. I'll go with it. We'll come back to it because it is an important. When these conversations started early on, I said, you know, I have this feeling that people aren't completing documentation because maybe I only did an 8-minute note or 8-minute session with someone. That's reimbursable, but they're not going to spend 15 minutes or 20 minutes writing that note. And so I just had this feeling that I wanted to flesh out, which was proven in our data.
Yeah, like especially on the case management side where there's
Yes.
high volume, they can do, you know, they can bill it at 6 or 8 minute increments, but it could take 10 minutes or longer to write the note. And we even had some folks say, hey, I'm not, like even grade 8.
Some of my best employees were like, I really just don't write that note.
Like,
you know,
I can't get to it all the time. I feel bad, I can't get to it. And so we had this really great partnership with these 2 agencies and two others as well. And we first rolled it out to about 20 folks at each agency. And then by the end of Q1, we started to roll it out early access and have been rolling it out to our existing customers, and then also recently selling it to folks that are on other EHR systems. And we've got some really great data that Mary and Sue will share, but it was really fun for us to just have I mean, this is just as much about this case study, this tale is really just as much about how productive it can be when you partner with a technology provider, whether it's us or whomever you're working with, because there's so much domain expertise in the Medicaid, behavioral health, and human service space and it's so nuanced, just the complexity of it, that, you know, you need that type of partnership to be able to really understand. It's not like one use case, like, yeah, here it is. You know, we're very specialized. We only do one service. I wish you guys were more specialized sometimes because it makes our job a little easier. But it's like, oh no, we do like.
We do keep adding on.
Yeah,
So Peter, you have someone you know in the back of the room who keeps putting up a sign that says next slide.
Yeah.
What is that about?
Oh, okay. Yeah. So sorry, that was my daughter.
I thought it was a stranger.
Yeah.
Do you know him?
I do know. Just keep on track. Yeah, that's my daughter, Bells, and we named the product after her. And so she was the one who sort of said, hey, Dad, why don't you, if you're so smart, create a Grammarly for them. That's when she's a very happy kid there. Yeah, yeah, we get that question. Her brothers are like, when are we getting a product named after us?
College, think college.
Yeah, exactly, college. And so it's been a really great, you know, I mean, it's been a couple years in the making, but really the last 3 or 4 quarters it's been moving really fast. We're adding rules as we go. We're learning a ton. And then we've got some great data. So I'm going to pass it over to Sue, who is with Wings, and she is going to introduce herself and her agency, and you can stand wherever you'd like.
Okay, I'll go where you were. That sounds good.
All right.
All right. Hi, my name is Sue Amaro, and I am the operation manager at Wings for Children and Families. The executive director, Trish Niederowski, is on all the slides because she was originally going to be here, but she ended up having brain surgery. I think that's a good excuse.
But she's
right?
okay. She's okay. She's doing well.
Great. She's doing great. It was wonderful. It was unexpected, and she's back at work already, but she's not quite up for a trip. So here I am, and I've been the project lead on Bells and actually CT1. I'm the person that assesses different programs, identified a need for a new program, assessed programs, chose a program, and then oversee the training and everything that goes with it. So I certainly know the implementation piece and can speak to that. So,
and I think you have some other
Yeah, I know, they seem a little out of order. Here we go.
So yeah, there you go.
Here is Wings. We are in Maine. We were founded in 1995. We got a big system of care grants, one of the first ones, and we provide case management and only case management, which makes us quite unique. It was a deliberate choice to provide just the case management, to have more voice and choice and not refer to ourselves and everything. And we are really all about the children and the parents. I mean, that's number one. We all are, right? But we say it a lot. So we now are providing case management using the health home model, the behavioral health home model, which I guess is sweeping the nation. If you don't know about it, I'll be happy to tell you more about it later. And we also provide to a much smaller cohort targeted case management for adults who have developmental disabilities. We serve over 1,000 people at any time. We employ over 60 staff, and we serve the upper half and eastern half of Maine, definitely more than half the state. So we are definitely rural, let me tell you. We have locations where we serve families where there is no internet, no matter what. There just isn't. It isn't available. So having that ability to do those mobiles offline is really critical. So we joined the Bells looking to, let me just check, make sure. Oh, here we go. Our agency's goals. We're always trying to improve the quality of our services to families. That's our number one goal, as it is for all of us. However, you can't meet that goal without number 2 and 3. And number 2 is to increase and maintain staffing to assure that we can serve all the kids that are coming to us. And we're in the same pickle everyone else is right now with, we have a lot of openings and we're really trying to hire. We're in competition with other agencies. You know, the bonus stuff is getting out of hand. But we're hanging in there, we're doing fine. And we are really big on communicating, collaborating with communities to create better system of care, which was one of the reasons why we were so interested in being part of the development of Bells, because we really are about the greater good. It's in our mission statement. So we wanted to improve staff productivity, most definitely. And the notes, we were having a really hard time with note quality, timeliness, and actually missing notes, which affects the bottom line. So we went through the process with Bells, and once we were ready to pull the trigger, it was within a month we had everybody trained, every single person, which is easy when you have just over 60 staff and only one service. Mary's going to talk about more complicated situations. But having said it was easy, it really wasn't easy. Change is hard. Everyone can do it, just some people take longer. The impact has been amazing. I'm so impressed. We've reduced session to sign time by 67%. You can see these numbers as well as I can, but I'll go over them anyway. Improved note writing time by 72%. The direct support people wrote more notes every week. I think it might be more than that. And the revenue has increased. I just got an email today that we're getting a bonus for quarterly performance as an agency because our revenue is doing really well. And Trish's quote is that Bells has been transformational to our agency and staff in terms of revenue generated, staff productivity, and note quality. I want to talk about what we learned. Healthy communication and the relationship with your vendors are so important. And Peter has not asked me to say this. He doesn't pay me, we pay him. But I just have to say, we really love this product, Bells. We really, really do. And our relationship with the vendors has been great. They're not like in some phone tree in the middle of nowhere. You know, they've been here for us. And that's what makes a good product, when you can really communicate and Peter and his team really listen to us and get into the weeds of the use, you know, the case use and everything. It's been amazing. And our staff, they want to have a voice. That's all related to turnover. Staff turnover is that they feel disempowered and not respected. And we've had staff involved throughout the whole thing, not just the key players that were part of the initial development piece, we would transparently share what we're learning, ask for feedback, invite them to feedback sessions to tell from their perspective as case managers how this new product was feeling for them and what they'd like to see added or changed or tweaked. And the remarkable folks listen. That's hasn't been my experience in previous things. So what it did was it helped everyone buy into it and feel excited about it and to see the value of the product and how we want to make it, how we want to make their work easier and more fulfilling and enriching. The tools, we've already talked about them a bit, but I am so impressed with these tools. Number one is because they're really easy to customize. Not necessarily for case managers. You know, you have that bell curve. Some of them are like, I don't know, it's, you know, technology, I can't touch it. But some of them can, and we can do that behind the scenes fairly easily. It's really wonderful. So some of the outcomes that we've noticed was that the notes with the different features on them, let me go back to the features again. The clinical notes, those are, correct me if I'm wrong, John, that's the note that, this custom notes, okay, the clinical notes are the ones where you can set up expectations, sort of like a Grammarly, and help people be more objective versus subjective. And I think you talked about a case study with the transportation. We do that with similar items. And I'm thinking of some people in my head right now who just love that because they're never sure. They don't have a lot of confidence when it comes to the administrative side of their job. And they really appreciate those little pop-ups that come off to the side. They're really gentle. They're pretty colors. And they look at them and they're like, oh. And then I have this other group of people who say, I want to beat those notes. I don't want them popping up. They don't want to see that little color pink thing saying, did you mean he reported he was feeling depressed? You know, if someone says he was depressed, right? And they want to beat those. They don't want them to come up. And I love that. And then the drop-ins, those are like little pieces of text that you can pre-populate to help people, those new case managers that were referred to earlier, who are a little unsure of what to write, and they have this little thing and it says, oh, I know what to write. Here it is. They put a few words or a few letters and there it is in their note for them. And when I think about when we get back to working with families in their home, which we're only doing in a small way at this time, that will really allow you to do those on the way notes. You're right in there. You don't have to be looking at your computer, your tablet or your computer instead of your client and their family, other than to put in a few letters to get that to pop in for you, or to use the scribbles, which is a really cool feature that you can do some text, you know, to say, hey, hang on a second, let me make a note of this for later. And you can say, yeah, mom said the school is blah, 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 and dad said blah, 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 you know, and then you have that for your note later. It's really nice. And then the other thing is expansions, which I really like, you know, where you can expand an acronym, for example. People are crazy about acronyms, and we're not going to kick back every single note for the acronym because we never get to the billing side, right? So this is doing it for us. Yay. So this has been really nice. So the outcomes are that it reinforces the training. You know, the orientation we do at the beginning, it just enforces it on the way, because, you know, people are too busy to go back to their training materials. They are. The consistency of the documentation is so important, and we're really happy to see that. Staff have reported feeling less stressed. They like the feel of the product. It's just pretty, it's bigger, you can see it better. And that's been very popular. It's easy to use. Fewer notes are being rejected. So we have QA staff that review certain types of notes before they go on to billing, and they're not having to kick back as many. Actually, very, very few. And the QA people, I'm thinking of 2 of them, have reported that to me on their own. They said, you know, I'm not having to kick back the notes as much, which is huge. Because, you know, for a staff person, you know, you want to talk about retention. That's our big deal right now, right? You know, being told you're doing something wrong all the time, that's not fun. Increased notes overall, most definitely. We have seen that in, I think the stats come at the end. and fewer late notes. Again, there's a little feature on there. I don't know where they put it now. I haven't entered a note myself since I first saw it, but it tells you, 36 hours late, and people want to beat that. They don't want that. And you can access this easily through a website on your mobile, and that makes it, you don't have to wait for a program to go and, past all these security things. And it's a very popular feature we have now. What our staff are saying, I asked for some quotes, and I love the grammar and spell check. The program we had before CT1 and Bells did not have a very good spell check, and that was probably the most frequent complaint I had. The notes are much easier to create and sign, easier to see. We have, I'm seeing this more in younger people too. I don't know, I blame technology, but we're seeing people that can't see well. They go, can you pop up the resolution for me? Make it bigger. And you go to the Wells website, you just go up there and zoom up. It's great. And it's so easy to check. They have to check every month to make sure they have all their face-to-face meetings in, and they can do that really easily in Bells. It was much more complicated before the way we were doing it. So it's been, I bet that saved, an hour's worth of time a week for everybody, just that one piece. And so some closing thoughts on this. What this is allowing us to do, and we are doing it, is to focus less on administrative trainings and retrainings and big long emails and all that, and do more of the clinical stuff. That's what people really need, because it's what I said at the very beginning, it's all about the kids. It's about the kids and their parents. Oh, and one other case use that we just started doing, well, actually, we're not going to do it until I get back from this trip, but we talked about it, is that small little portion we have of adult case management that we're doing. It's a program that's more closely monitored by the state of Maine's Department of Children's Services. And you know how it is, when it's a state department, it often is more bureaucratic. So they are very confused sometimes. And we studied the notes, which was easier to do in Bells, by the way. We studied their notes because they were getting low billable time. And we discovered that they have been writing notes and marking them as non-billable when they were indeed billable. So we're going to use some of those features we talked about to catch that and help people, because you can play around with different note types and match them with service types. And the customization is just brilliant. I think that's about all I have to say right now. And I'd be happy to answer any questions anytime.
We'll save the questions and let Mary do her piece at MHA, and then we'll have time for questions.
I'm going to talk a little bit about our organization, and I'll come back to this slide a little bit just so that to give you some context. My name is Mary Jones. I'm president and CEO of the Mental Health Association of South Central Kansas. We've been around since 1957, so we've been doing community-based work for a very long time, and we have about 180 employees, and as Pete mentioned, over 32 programs. Much of them are direct service, most of them are direct service. This includes clinical services, outpatient therapy, substance and medication management services. In addition, we do community-based services for adult and children, case management, supported employment, psychosocial rehab services, for the whole gamut. Additionally, we have 24-hour housing services. We happen to be the largest housing provider for people with mental illness in the state of Kansas. So we've lots of units, lots of people in beds. So fairly complex in addition to some of the prevention work that we do. We serve over 10,000 people each year. So we're looking as a nonprofit at opportunities to really enhance what our staff are engaged with. So we've been a partner with Remarkable Health for years, and I know, Pete sort of referenced this, but when he called and said, hey, can we just have some conversation about a few things? What are your biggest pain points? And they certainly are in the areas of turnover. You'll hear the same thing we're all dealing with, right? So I'm just going to get to a highlight, and I'll come back to the outcomes at the very end because it's one of the final slides. When he approached this, is talking about how can we improve productivity and engage the staff in a product that they're excited about and help their clinical work improve. So we did implement in 3 waves because of the complexity of the types of services, and we really took tiers. We took people that would be cheerleaders first, and those were technology friendly staff who are excited about new things. That was our group 1. Our wave 2 were the more ambivalent people who could get on board pretty easily. And our wave 3 we all have them in our organizations, the people that are like, will they ever get it? You know, we might just have to abandon them altogether. We're not really sure. Interestingly, though, as we worked through these processes really quickly, we found some of that group 3 were really surprising, because groups 1 and 2 had been so excited about the product. They're like, I'm going to learn it. I'm going to do this. And lo and behold, the product is so easy to use. Even the people that, you know, are these people were able to use it really easily. So we'll come back to the impact at the end. I'll tell you some of our exciting things. I will, though, go ahead and talk about the fact that we did have a 16% increase in revenue per provider. We've only been in this since early this year. So as you look at these numbers, what I'm excited about is this isn't even a full year of data for us. So some of the things that we were really concerned about, I think, are the things that we're all concerned about. How do we serve people, provide the highest quality services to the most people we can? How do we keep our staff? How do we keep them excited and motivated to do the work? Certainly one of the issues in front of all of us right now. And then financial sustainability. We can't do the work that we're going to do if we don't have the revenue in place to do it. And again, those hypotheses that we had about, I think we're leaving things on the table, and we need to shorten the revenue cycle, because what Pete mentioned is exactly what we were seeing with our staff. They weren't writing notes timely, and so they were doing these data dumps at the end of the month, and we couldn't get a handle on cash flow as it's coming in. So that was a real important initiative for us. What we learned is very similar to what Sue's group learned, which I was kind of excited when we put our slides together of how similar we were in the content with very different organizations in different parts of the country. Staff want solutions. So one of the coolest things is one of our staff member who's been very involved in this project was saying, you know, people were saying to her, I can't believe, you know, that Mary would invest money in technology for us so that we could do this. And I'm kind of humbled by that statement, but the reality is I'm investing in keeping them happy, and I'm investing in a quicker solution with less errors. Also, you know, people got really excited really fast, and they still get really excited because we are making changes as we go. For some people who don't have the stress tolerance at that level, don't like change, that can be a little disconcerting, but when they see the new thing that comes out, then that enthusiasm keeps them going. The customization pieces have been really critical. I did compliance for years for our organization prior to being in this role, and I know the audit pains. And it was really important to me that we create a solution that has those built in. Our supervisors, we don't have QA people that are looking at the notes, it's our supervisors. And so our supervisors were saying, you know, I'm spending, the staff are spending 2 days, we're spending 2 to 3 days, and we're just in this cycle of loop return and audit and checking, and it's a never ending cycle of note looking. So we wanted to eliminate that. And then collaborating with a partner. We'd been a partner with Remarkable Health, so it was easy to work with this group, but I'll tell you, they took the feedback really to heart. And, you know, those conversations were a lot of fun, even explaining why we do the things we do and why we have to do the things we do, but they were listening, and I think that really shows in how the product has evolved and will continue to evolve. So here are some of our outcomes that we're really excited about. We reduced session to sign time by 50%. So we too have tried concurrent documentation, and we really support the collaborative model, how great it will be in the ideal world if you sum up that session with your client there and what are we going to do between now and next time. It's not functional. It's not functional because of where people are doing the service. It's not functional because they don't want to transition that time and write the lengthy note. But what we do know is it is possible for someone to jot this scribble down and have it translate. So that was really exciting for us, for sure. Improved the note writing time in general by 49%. So from session to note, great improvement. My revenue cycle gets better. And then the improved note writing time in general, where you don't have, as someone looking at audit and progress note, the trail of when did the session happen and when was the note written. And, it's really problematic. And then the other piece to this is staff can go home. There's a quote on another page about that really reminds me of how important this is for the staff health. Our average direct support professional wrote 28% more notes a week. So I was right. We were leaving things on the table because why do I want to write something for 15 or 20 minutes when it was only a 8-minute interaction, and who's going to know the difference anyway? You don't know what you don't know. So that was a really impactful statistic for us. And then the average revenue went up per person by 16%. Again, we're just starting, so this is really exciting for us in terms of sustainability. What our staff are saying, again, getting back time for clinical documentation allows them to see more people, which is also one of the outcomes that we want. Someone else says, I couldn't be happier. We were able to guide staff through the documentation process in a way I couldn't have imagined before. When we onboarded people into our agency, it was taking 3 weeks to get them kind of up and running in our EHR. We're doing that within 3 days now. They're writing notes. It's really just getting through the manual and handbook and shadowing, and then they're writing notes. It's incredible. I was able to leave work after 10 minutes of writing notes rather than an hour and a half, right? Work-life balance. We preach it to our people. We preach it to ourselves, but then at the end of the day, we're like, stay and get your notes done. So it's allowed us to have a little more credibility in that too. And then doing my intake and therapy notes is so much simpler. This is someone who does a lot of notes, and she even admits I struggled with the balance of getting that documentation. I had this particular person went from writing notes that would take about 15 minutes to less than 90 seconds with all the tools. So pretty excited about that. That's my part.
You done?
Yeah. Do you want me to keep talking?
No. It's all right.
Oh, I can do that.
She will too. So that's we have control over the microphone. Listen, thank you so much, folks. We have about 10 or 15 minutes for questions. I would like to preface our Q&A piece by thinking out loud about 2 things that I've heard here. One, and you can certainly visit the Remarkable Health booth in the exhibit hall, is the technology tool. This mobile AI tool that can be bolted onto an EHR to help people do their documentation and get some of the benefits that our friends have been talking about here. But the other piece that's really important, and some of you heard me talk about this yesterday if you came to my session about selecting an electronic health record, has to do with working with a vendor and partnering with a vendor. So I would ask you to listen to both of those when you're learning lessons from our friends here today, because it's not just about the technology, it's about working with a vendor. So let's ask them really hard questions, because we have like 12 minutes. So questions for either of the case studies or for Peter himself? Yeah.
I'm curious, how did this impact patient outcomes, and did you measure this?
Yeah, so the question, if you didn't hear it, is do we know anything about quality or outcomes as far as where's that impacted? Sue or Mary?
Yeah, I haven't. That's one step of the process. We're not there yet. And I think we'll see. Can you hear it okay? We'll be able to have better tools that we'll be able to report out some things. But I think our initial data was really on the use and the investment that we're making. But absolutely, it's on the pathway.
Yeah, I'd like to say that we're at that place. Trish has asked me, she said, how do we find out how that affects clients? So it's something that I'm sure she's going to give me as a project. But I do think that some of the clinical note, having the notes be a better quality will allow us to continue following that client in a, a smoother fashion, yes. That's a good
Well, one
question.
of the things that I think one of you shared, or maybe it was another group, but I don't know if you would agree, it's on the path to outcomes, but it's not quite there. Is just we've heard supervisors are now having more time to coach on actual, how they're engaging with their clients, because they're not spending so much time on, we didn't write this the right way, and I don't know if you would agree with that.
Yeah, I mean, much of supervision that happens is you need to correct these notes. And I mean, it becomes this administrative supervision. And that could have been me. I have likely said that. We're able to spend more time in the practice of working with people.
I did have one of the supervisors responded to my request for quotes, but I didn't put it in here. She said, "I'm so tired of correcting people's grammar." And she goes, "I really love this product for that."
Well, and one of the outcomes I don't know that we can measure exactly, but I would certainly expect from the technology we're using here is the ability to have up-to-date information about the clinical services we've been delivering. Because if we have that delay in documentation, if Isamu is another case worker for the team, he's not getting the note that Mary did because she didn't do it yet. So I don't know how do we measure that, but I think that's a big piece of it, is making sure we have as updated information so that all care providers are part of that. Yes, Isamu.
Just wanted to add that this is my first time hearing about remarkable health, but what you presented makes me think that if providers have a better work-life balance, better mindset, right, that should translate to better interactions. And so that may not be exactly measurable as an immediate outcome, but I can imagine that's an added goal to how we find care.
Yeah.
That should make an impact.
Yeah, well, they both mentioned it wasn't just about getting notes in more accurately, getting more things done, but that staff reported that they liked it. It was easier, they could go home.
You're seeing, if you have a case manager or a therapist and all of a sudden they quit and you have to get a new one, I mean, that's a lot of rebuilding of rapport. So I think if it's helping with get more people, keeping more people in their seat, that's probably pretty easy correlation.
Yeah, absolutely. Anything that I can do to have staff be happier, that's going to improve everything.
Did I have a question back there? Yeah, let the mic come up to you. Thanks.
I was wondering if you could talk about what the process was like in working with Pete's team when you said, hey, we need these changes made. This isn't working. This is kind of how our staff thinks it needs to be.
So tell us more about that collaboration process to help build the product and how it worked, to either one of you.
And what the turnaround time was it weeks? Was it months? Like if you needed to make a modification?
It isn't months. It was in the beginning, in the information gathering stages, we were in weeks. But once the product was live and we were talking about if there was a problem or a tweak or something that was happening within 3 days, generally we'd have the responsiveness and the fix for it. So again, we're talking about, we started this, we actually started in February? What month did we start it?
We went like live with some of your like 20 users in technically late January.
Yeah. So I mean, we were talking about a very rapid cycle here that we've been working.
I think the other thing that was notable too was that we were encouraged to invite several case managers, in our case, that would be part of the process. And I consider myself, I was deluding myself that I knew what they needed and that I was close enough to their work, I could speak on their behalf. So I was grateful, and I certainly immediately recognized the value, but I was grateful that Remarkable recognized that value. And the case managers that were part of the beginning were so tickled that their little tiny thing, like, could it be on the other side of the screen? Something that minute was being listened to and taken importantly, that they went out and told others. And so the group that is always the late adopters and like, I don't like change, they were excited and curiosity was piqued.
So end users were really part of the development process.
Yes.
So it wasn't just you guys as supervisors or executives. It was, the folks that were using the software giving feedback both to you as well as to your partner, Remarkable.
Yes.
Great. A much more difficult question, please. Just like to keep it interesting. I mean,
Okay.
it's 3:30. But other questions, comments? We have one over here. Oh, Mike's going over here. Sorry, we'll get over to you, I promise.
Thank you.
It's important she runs back and forth. We're going to try to do that for at least 7 minutes. Go ahead.
I think one of the product groups mentioned improvement in your overall internal quality auditor scores. Have you guys had the chance yet to be audited by a payer or to have case reviews done by a payer? And do they have the same assessment of the notes and the quality of the notes
Yeah.
that your own internal teams do?
Yes.
Excellent
Did
question.
they come in and say, God, your notes are brilliant now?
Well, I've really never had an auditor say things like that, but can I answer it on the no news is good news front? And I mean that seriously. I don't have an expectation. We've had 3 fairly large audits since the implementation, and we haven't had any issues with that. So, normally we would get some
Long list
feedback.
of things you might do better.
Yes.
Yeah, we had a licensing visit since we've implemented bells, and he loved it. He said, I'm really, pleased to see that, he was really impressed by the program and what it was bringing to our documentation.
Very good, very good. And we had a question hiding over here, I think.
So it's platform agnostic. How is it that you connect to various different platforms?
Yeah, great question. So we built this product intentionally to be able to, with open APIs, to be able to integrate with other EHRs. We first have rolled it out. Priority was to roll it out to our existing EHR. And then we've gotten kind of consistent with the data that Joe Paul shared, which is about 3 times more of the market. For every 1 person that's looking to replace their EHR, there's about 3 people that are, or agencies that are looking to bolt on to their existing product. And so what we're doing is we're working with a third-party integrator and the customer and the EHR that they're working with. And so we've started that process right now.
So that was the widget answer that says they like connected, right?
And it's via API, via RPI. I mean, there's several ways we can do it, but essentially we want the data that we're pulling into Bells, so it's a seamless experience, is their client roster, potentially their schedule, past progress notes, so they can see their diagnosis, and so some of that basic information we're pulling. We're not writing to that, and then we are writing and sending a signed note into the EHR, and it would go through their existing QA process. And so we've already started to work with another EHR and expect to be adding a lot more to the mix as time goes on.
Did he get that for you? Okay. Another question, comment? Back here we have Gordon in the middle.
So as much as the standards are supposed to be the same, I suspect that California has different expectations than Maine does. So does the software have to relearn so we get to bill for documentation?
Yeah.
We get to bill for transportation.
Yeah.
So you don't necessarily have to have those kind of tweaks. So is it designed to adapt to these different kinds of standards or expectations?
Yeah, great question. So those rules are all agency and program specific. So it is not we're not crowdsourcing rules from Kansas and assuming that they are appropriate for a specific agency. We wouldn't even do that within another agency in Kansas, because they're all like a snowflake. Every agency is unique.
He means that in the most endearing way.
Yeah, I took it that way
Just
too.
to be-
I mean, it's very unique. And so, I mean, the thing I learned is the most common answer I heard to every question I answered when I first got into this is, it depends. I have a good question. Yeah. So all those rules, we would, if we were setting up someone, we'd say, hey, this is what other folks are using. These are rules. Do these fit? You say yes or no. You turn them off. You add a new rule. It's pretty customized. I mean, it's completely customized.
And that's great too, because just thinking through how long I've been in this field, rules change right? And so different payers have different expectations. So as those things ebb and flow, we'll be able to change those.
The AI is really about understanding the sentence that was written and connecting the dots with the rule that they want to implement. It's not creating rules itself, if that makes sense.
Well, time for one more question, and there's a microphone right at your right hand. It just appears.
Is there a repository then to that end? You're talking about rules. Is there a repository of rules that others of your agencies can share?
Oh, like if I'm a new customer, is there like a
So
library of
exactly. So
rules?
if you were a new customer, what we would do is we're aggregate as, and folks are, Mary might create 5 rules tomorrow. I mean, you can create rules as you go. So we are, part of our implementation process is we're collecting those rules and then we're saying, hey, here's what others have used. So you don't have to start from, I mean, 'cause it's a little new to think about rules in this way. So we don't force you to start at 0. We give you a list and you can opt in or opt out and then create your own.
Right, but will Mary then have access to the new rules that customer number 42 has developed?
That's a good question. We haven't done that yet, actually.
Oh, to have sort of a joint library.
Like a recurrent, yeah. I mean, we would share that. We haven't done that though. We'd have to think about how to introduce that to the UX experience, the user experience. That's a great idea.
Well, listen, we are running out of time for our session. So I like to end it with a quote from Peter that providers are snowflakes, right? I think that's what he said.
Oh, I want to thank you all for you all have joined me for my birthday today.
Peter's 44 today. But listen, a round of applause for Peter and his team, as well as for our case studies today. Remember to visit them in the exhibit hall. They'll stick around as long as you want. So just come up here and you can have all their time, all right? Thank you so much, folks.